we will be talking about IV induction agents. And this will be the sequence of all the drugs we will be discussing about. So first we'll talk about propofol. As you can see the physiochemical structure of it, this is a phenol ring with propyl group present at 2 and 6 position. So it is 2,6-diisopropyl phenol, or you can say it is alkyl phenol with a pH of 7.8. Contents are 1% of propofol, 1%, 1.2% of egg phospholipid, which acts as emulsifier, 2.5% of glycerol, which maintains the tonicity, 10% of soybean oil, which maintains the medium, which acts as a medium, and we have EDTA as bacteriostatic agent. It is present in 20 ml, 10 ml, and 50 ml vials, and we have concentration of 1% of volume by weight. We have 10 milligram per ml. Coming to different formulations, it is present in Diprivan. Diprivan is to be diluted with 5% dextrose. It has a sodium hydroxide which changes the pH to 8.5. Earlier, a generic version was used which had a lower pH and had sodium metasulfide, which was causing what? It was causing bronchoconstriction. So it is not used nowadays. Coming to very important formulation, that is Aquavan, which is also known as phosphopropofol glycera or phospholo-O-methyl 2,6-diisopropylphenol, which is a prodrug. What does it do? The 1.8 milligrams of phosphopropofol is degraded by liver and is converted to propofol plus formaldehyde and phosphate as byproduct. What does formaldehyde do? It causes perineal paresthesia or pruritus. Although it is a water soluble, it decreases the pain during injection, and it has slower onset of action because it is more potent and has more volume of distribution. Coming to other formulation, that is cyclodextrin. Cyclodextrin, how does it work? It makes the complex with propofol, which makes it water soluble and hence again makes it painless. Coming to Lipuro, propofol earlier had only long chains. Now in Lipuro, we have mixed both long chain and medium chain, which decreases the pain on injection. Coming to Ampofol. Ampofol has everything 50% less. As you remember, propofol had 10% soybean. So it has 5% of soybean oil. Propofol has 1.2, it has 0.6% of eclecithin. It makes it more painful. There is no need of bacteriostatic agent. Coming to pharmacokinetics, before understanding pharmacokinetics, you just have to understand the hydraulic model. Multi-compartment hydraulic model. What happens to the propofol after it is injected? After injection, there is rapid redistribution to vessel-rich group. Can you name vessel-rich group? And then there is intermediate redistribution. Then there is slow redistribution. Okay. And what happens after single dose of propofol? After single dose of propofol, there is rapid redistribution and patient wakes up. So, after single dose, patient wakes up after rapid redistribution, that is 1 to 8 minutes. Then there is slow redistribution. Then there is elimination half-life of 4 to 23.5 hours. Then there is context-sensitive half-life. What is context-sensitive half-life? This term is used for infusions of the drug. After you switch off the infusion, by how much time 50% of the drug concentration is left as the in the body. That is the context sensitive half-life. So if it was used for 8 hours, there is the context sensitive half-life is less than 40 minutes. If it was used for 3 hours, it has a context sensitive half-life of less than 10 minutes. Coming to metabolism. It is metabolized in liver, it is metabolized in renal and also lungs. In liver, what happens? With the help of cytochrome P450, it undergoes hydroxylation and makes 4-hydroxypropofol, which has 1/3 of hypnotic activity. And in lung, what happens? It is transformed to either it comes back to circulation after first pass in the lung, or it is transformed to 2,6-diisopropyl 1,4-quinol. Both these components are excreted through kidney. Coming to major pathway of metabolism of propofol is glucuronidation, and enzyme responsible is uridine 5-diphospho-glucuronosyl transferase. If you can remember, it will be good. It is expressed in kidney and brain. Coming to mechanism of action, it acts on GABA receptors. What is GABA? GABA neurotransmitters are actually major inhibitory neurotransmitters. We have excitatory neurotransmitters like glutamate, and we have inhibitory neurotransmitters like GABA. Propofol acts on these GABA receptors. See, it acts on GABA A receptor, which has all these subunits, 2 alpha, 2 beta, and GABA. Different drugs acts on different interactions, causing increase or decrease in the function. So, propofol acts on GABA beta subunit and it increases the chloride conductance. By increasing the chloride conductance, it increases the hyperpolarization of the postsynaptic membrane. It also inhibits NMDA subtypes of glutamate receptors. How it increases the chloride conductance? By decreasing the dissociation rate of GABA from these receptors. So hence it increases the duration of conductance. Coming to dose, I'll tell you the easier way to remember. See, antiemetic dose of propofol is 10 to 20 mg. You multiply it by 2, the dose of sedation comes, you multiply by 2. Maintenance of general anesthesia, multiply by 2 of 1 to 2.5 mg per kg. We have induction dose. You can always remember the other doses. These all are present in Miller's. Coming to, it has an anticonvulsant effect also. And what is the dose? More than 1 mg per kg IV. What does it do? It decreases the seizure duration by 35 to 45%. It is acting as antipruritic also. What is the dose? Again 10 mg IV, and it is used in opioid associated pruritus. You might have seen that after giving fentanyl in spinal anesthesia, patient might be complaining of itching around the belt area. So you can give propofol in that, and it can also be given to pruritic patient with cholestasis. See, for unconsciousness, you need a blood level of 2 to 6 milligram per ml. For patient to wake up, it should decrease to 1 to 1.5 milligram per ml. Coming to its effect on central nervous system, it has a hypnotic effect. How so? We already discussed that it acts on the beta subunit of GABA receptors. GABA is gamma aminobutyric acid and induces the chloride channel conductance. It has direct effect, it has indirect effect. Directly, it causes depressant effect on neurons of spinal cord. Indirectly, we already saw activation of chloride channels and inhibition of glutamate receptors. Also, it causes a sense of well-being, which this drug was used by a famous pop star. He abused this drug. Can you name that pop star in the comment section below? How it causes sense of well-being? It increases the dopamine on nucleus accumbens, and it has an anti-emetic effect by decreasing the serotonin in the area prostima. It causes sedation and amnesia and dose-dependent anticonvulsant effect. Coming to its effect on cerebral blood flow, it decreases the cerebral blood flow. It decreases the intracranial pressure, and hence there's decrease in the central perfusion pressure also, decrease in the oxygen requirement, and decrease in the intraocular pressure. You might have seen in cerebral physiology, you might have come across a graph in which you might have seen the reactivity of PaCO2 with cerebral blood flow. The funda was that if you increase the PaCO2, there will be increase in the cerebral blood flow. If you decrease the PaCO2, there will be decrease in the cerebral blood. So basically what I'm telling you about this, why I'm telling you this is because in propofol, this autoregulation is maintained. So that's a good part. So after induction with propofol, the reactivity of CO2 changes and autoregulation is intake. Coming to what is the endpoint of induction of propofol? So induction of propofol is heralded by verbal response. If you give etomidate, if you give thio, you see what? You see eyelash response. But during propofol, you might be seeing someone telling to talk to patient and count from 1 to 10. That means we are seeing what? Verbal response. So anesthesia is heralded by verbal response. Coming to somatosensory evoked potential, it is not affected by propofol. High doses causes EEG burst suppression. ECOG recording, which is used in awake craniotomy, can be done with propofol, provided you stop it 15 minutes prior to the mapping. Coming to cardiovascular effects, it causes sympathetic blockage. That leads to vasodilation, that leads to hypotension. So you have to make sure patient is adequately hydrated, especially in elderly, dehydrated, and left ventricular failure patients. It completely upends the baroreceptor reflex. So if there is decrease in the BP, there won't be much change in the heart rate. But in some cases, it can cause brady and even asystole. And if it attenuates, if there is brady, it might attenuate the heart response to atropine. So there might be use of epinephrine required. Okay, so there's not much change in the heart rate usually. There is decrease in the systolic blood pressure, mean heart rate pressure, and systemic vascular resistance. It does not causes any change in SA node or EV node, so it can be used in major ablative procedures or like WPW syndrome, and it decreases the cardiac output. Also, it has more chances of increased chances of ocular cardiac reflex. So you have to treat it with atropine or direct beta agonist. Coming to its effect on respiratory system, it causes dose-dependent depression in the ventilation, decreased tidal volume and frequency, causing decrease in the minute ventilation. See, if there is decrease in the minute ventilation, ideally there will be increase in the CO2 retention. But that is not the case with propofol. Why so? Because there is decreased metabolic activity also, so the CO2 retention is also decreased. It completely upends the ventilatory response to arterial hypoxemia and airway reflexes. So it is ideal for LMA, and it attenuates the bronchoconstriction by direct smooth muscle relaxation. You saw this content, metasulfite, somewhere. Can you tell me where did you see this? It causes bronchoconstriction. Yes, you saw this in generic formulation of the propofol, which was older version of the propofol used. What does it not do? It does not affect the hypoxic pulmonary vasoconstriction, does not enhance neuromuscular blockade, does not affect corticosteroid synthesis. Can you name one IV induction agent which affects corticosteroid pathway? It does not alter coagulation or hepatic or hematological functions. It does not trigger the malignant hypothermia. Can you again name the drugs causing triggering malignant hypothermia? Now coming to its effect on liver and kidney. Prolonged infusion might cause hepatocellular injury, might cause propofol infusion syndrome. You might see green urine also because of the phenolic content of the propofol, and you might see cloudy urine also because it has a pH of 7.8, which combined with uric acid can cause turbidity. Coming to uses, we have seen the in and out of propofol, so it's easy to see the uses. Coming to induction, it can be used for induction and maintenance of anesthesia. It can be used for sedation, but if it is being used in ICU, you have to see signs of arrhythmia, unexplained metabolic acidosis. Why? Again, it can be used as antiemetic, antipruritic. It can be used to attenuate bronchospasm in bronchial asthma, in hypertension, during extubation. It has an antioxidant property also. The phenolic group of the propofol scavenges the free radicals and inhibit lipid peroxidation. It also scavenges peroxynitrite, which was a potent bactericidal. Hence, it suppresses phagocytosis. Coming to side effects, it causes irritation of the venous adventitia, which leads to pain. So you can always pre-treat with 1% diglucane. You can store it in 4 degree. You can use a large vein. You can give rapidly, or you can just aspirate the blood before giving propofol, or you can use Nipiro. Can you tell me where did we read about it? Then it can cause myoclonus, it can cause hypotension, and it can cause infection also. So they have much more chances of infection with E. coli, with Pseudomonas aeruginosa. So therefore, if it is open ampule present, discard it after 6 hours, and if it is in tubings or unused portion, discard it after 12 hours. Can you tell me which part of the egg, white part or the yellow part, is present in propofol? You saw, right? The content. So which part? Comment below in section. Also, other fact is the allergic component of the propofol is phenolic nucleus and diisopropyl.
Side chain. Thank you for watching.